We've received a lot of questions from those of you here in the room, as well as those of you who are participating online, and we will work to get written answers to those questions. That document will be posted following the training, so if your question wasn't answered today and you have submitted it, it's not that we just don't want to answer your question, it's that we need to maybe confer back with some colleagues. Always keeping in mind that we're looking across 4 settings and want to make sure that there's consistent guidance amongst those settings. So we'll go with that. So we are going to begin section M with talking about the quality measures. And I had a question earlier about why some changes were made. So I will address that question as well. So very quickly, let me just again, welcome those of you who are on the web stream. I do want to mention that during section M, we are going to use some of those supportive materials that are in your packets if you're here in the room or are in that folder online. We'll be using specifically the case study and the excerpts of the section M item set. So here are our objectives for this section. We're going to talk about the intent of section M. We are going to look at the rationale and look-back periods. We're specifically focusing on M0300, M0800, although I am going to talk a little bit about M0210 as well. And then you are going to be working on coding some scenarios. But before we do that, let's start by looking at the quality measures. And the question I received from one of my colleagues during one of the breaks was, why did the specs change? You may have noticed within the last, several days, that there's been a new posting of the specs. And the quality measure specs for this item now, you're going to see that we use M0300 rather than M0800. And the reason for that is it really corrected, kind of leveled the playing field with the other settings. Think about in the other settings, the intent of this is to compare how did they come in and how are they at the end of the session. So in the SNFs, when you use M0800, you're having that look-back scan. You're capturing any time a pressure ulcer, maybe they had a pressure ulcer develop in the facility, so it's a new pressure ulcer, or maybe that pressure ulcer was stage 2 and advanced to the stage 3, but at the end of that SNF PPS stay, they are free of pressure ulcers. If you're using the information from M0800 and capturing all of those assessments over the whole course of the stay, you would capture that change versus these 2 points in time. So in order to make it consistent with the other settings, this allowed to capture simply those 2 points in time. Okay, so let's talk about what this is, what this change is. So the SNF denominator here is the number of complete resident Medicare Part A stays, and that's defined as the 5-day PPS assessment and the discharge. So that's the piece that really led to this change of not using all those intervening assessments. And that could be a standalone Part A PPS or a Part A combined with the OBRA discharge, except those that meet the exclusion criteria. The SNF numerator is the number of complete resident Medicare Part A stays that the resident, the assessments indicate the resident has had a change, one or more new or worsened pressure ulcers. And you can see on the slide here that now those new or worsened pressure ulcers are going to be captured with M0300 B, C, or D, and looking at the item in, do they have the pressure ulcer and the present on admission items, and we'll walk through these closely. And we are only looking at 2, 3, and 4s, so that's consistent with that short stay measure that we've known all along, right? We don't consider 1s and we don't consider unstageables in this item. And then let's look at our exclusions. Missing data, residents with missing data are going to be excluded if that data are missing on the discharge assessment. And residents who die are going to be excluded from the measure as well. If there's no initial assessment that would capture these covariate items, that will also be excluded. So what are the covariates? There is a risk adjustment here, and it is the covariates. They are collected at the initial assessment, and I think that that's a key point here, and that is, that has been the case right along. These covariate items are captured on that first assessment that you do, and these are that the resident has bed mobility where they require limited assistance or greater, bowel incontinence at least occasionally, and how frequent does someone have to be incontinent a bowel to be occasionally? 1? Y'all agree? Isn't frequently 2 or more? Yeah. And then diabetes or PVD, you'd capture that in section I, or a low BMI, and that's calculated within the specifications based on how you code the height and weight for the resident. So before we look at the select items in section M, let's review the intent of this section. In section M, the items document the risk, presence, appearance, and change in pressure ulcers. Other skin ulcers and wounds are also captured in this section and are documented in section M, as are some treatments. It's not all inclusive. There certainly may be treatments or issues that are not captured on section M. And clinicians need to be sure to recognize and evaluate risk factors and need to identify and evaluate skin areas at risk for constant pressure. And a complete assessment is an essential first step in preventing pressure ulcers and effectively treating those if the resident does have any skin issues. And a holistic resident-centered approach to assessment and care planning is certainly a must. When you're determining wound etiology, is going to be critical, 1, for treatment of the resident, but 2, for accurately coding the MDS. So we have an item, M0210, and that's not included here on the slides, but I think it's important to consider M0210 on the MDS as a gateway item into the rest of section M. In M0210, you're simply asked, does the resident have 1 or more unhealed pressure ulcers at stage 1 or higher? If you say no, you skip all the way down to M0900. But if you say yes, you continue right on down to M0300. And that's where we're going to really begin our discussion about these items today, and that is M0300. With this item, we're going to be first determining the deepest anatomical stage for pressure ulcers. And we're going to be sure not to backstage, and we do consider current and historical levels of tissue damage, and it's certainly important to capture that information in the medical record documentation when they're being admitted into you, really what stage, what's the historical information about that ulcer. We're going to observe and palpate any pressure ulcers to determine the true depth of tissue damage. And ulcers are staged based on the deepest level of tissue damage that is either visible or palpable. If the ulcer's depth is obscured by slough or eschar, the ulcer is going to be unstageable. And more information is going to be outlined in step 2 about documenting unstageable ulcers, including those related to slough or eschar, those with non-removable dressings or device, or with suspected deep tissue injury. The historical information about the ulcer available in the medical record must inform staging, because ulcers can't be backstaged, if the ulcer was classified as a higher numerical stage than it currently appears, that higher stage is what will be coded on the MDS. And there's no question that a solid system to ensure careful documentation and tracking of pressure ulcers helps to ensure accuracy in coding Section M, but importantly helps to ensure accuracy in clinical follow-up and appropriate care for the resident. So step 2 focuses on those unstageable pressure ulcers. We're going to identify those, and if slough or eschar prevents the clinician from visualizing or palpating the wound bed, that ulcer would be classified as unstageable. However, if slough or eschar is present but the true depth of the ulcer can be determined, it should be staged appropriately. So years ago, I cared for a lady who had an extremely contracted arm, left or right, I'm not sure which, and she had a very small pressure ulcer right over her tendon here in her antecubital area here. And it was covered with tons and tons of slough, but if you looked really close, there was a shiny white tendon that you could see. So I couldn't necessarily measure to get the true depth of that wound, but I sure could see an underlying structure evident in the base of that. So how am I going to stage that wound? 4, right? I see that underlying structure. So I don't necessarily, it's not a percentage of slough or eschar that you say it's obscured or not obscured. It's what clinically are you seeing in there? And if you can see that underlying structure, as we could for that lady, I can remember the doctor at the time, it was a wound care center, he goes, "That's a tendon, Jen." And I was like, ooh, yikes. It was really, really pretty dramatic. So you're going to want to consider each individual case and make the determinations appropriately. We may have pressure ulcers that are intact but appear as suspected deep tissue injury. And these also would be coded as unstageable, not as stage 1s. And if the pressure ulcer can't be assessed because of a non-removable dressing or device, it also would be coded as unstageable. And next, we're going to determine for each ulcer whether or not that pressure ulcer was present on the time of admission, entry, or re-entry, and not acquired while the resident was in the care of the nursing home. Again, we're going to consider the current and the historical levels of tissue involvement. And in order to make this determination, we're going to review the history of the ulcer, including the location and stage of the ulcers at the time of admission, entry, or re-entry, and then looking back into the medical record that you received about that resident and really gathering the historical information. And there's lots of they're not really coding tips, they're more of the instructions here, but I do want to draw your attention to a few that were revised or added as we look through these next several steps here. And I'm going to share with you what it says on the slide, but then I do want to have a little discussion kind of surrounding each one of these and really kind of try to bring those alive in a clinical example. So if we have a pressure ulcer that was present on admission, entry, or re-entry, and it subsequently increases in numerical stage during the resident's stay, the pressure ulcer is coded at that higher stage, and that higher stage should not be considered present on admission. So here's our example. The resident comes into your facility and they have a stage 2 pressure ulcer. And at that time, you're going to code, your MDS would say what? Stage 2, present on admission. The next MDS you're doing for that resident, between those periods of time, it advanced to a stage 3 pressure ulcer. So now it's a stage 3 pressure ulcer, not present on admission. Okay, so when they come in, you've got a stageable ulcer, it gets worse, that higher stage is captured on the MDS, it's not considered present on admission. If a pressure ulcer was unstageable on admission, entry, or reentry, and then later becomes numerically stageable, it's going to be considered present on admission at the stage that first becomes numerically stageable. If it subsequently increases, again, that won't be coded as present on admission. So let's talk about this one a little. We have a resident who comes in with an ulcer that's completely obscured with slough. You cannot see anything in the base of that wound. The slough is debrided, and we have a stage 3 pressure ulcer. That stage 3 pressure ulcer is a stage 3 present on admission. But now the ulcer becomes covered with slough or eschar again, and now you debride it again, and now, oops, it's a stage 4. Is it a stage 4 present on admission? No. Once it's stageable once, and now it declines, it's not present on admission. Okay. How about if a resident has a pressure ulcer that was originally acquired in the facility? I want to draw your attention to this coding tip or direction. Number 5 is a revised one. So this is revised in the draft of the REI User's Manual. If a resident who has a pressure ulcer was originally acquired in the facility, is hospitalized, and returns with that pressure ulcer at the same numerical stage, the pressure ulcer should not be coded present on admission because it was present and acquired at the facility. So this is your resident comes in with absolutely no skin problems. They then develop a stage 2 pressure ulcer in your facility. That is a stage 2 not present on admission. They go out to the hospital and come back with the very same stage 2 pressure ulcer. It is still not present on admission. Okay, and this is a significant change from how we coded this item. And it's really much more consistent with the clinical picture of the resident, right? Stage 2 that happened in your facility, they go to the hospital, that stage 2 still happened in your facility. Number 6 is an added tip. So the next instruction we're going to go over is brand new. And that is if the resident who has a pressure ulcer that was present on admission, not acquired in the facility, is hospitalized and returns with that pressure ulcer at the same numerical stage, it is still coded as present on admission. I thought I'd hear a thunderous round of applause. Yeah, yay, it clinically represents the true picture of the resident, right? That resident came in with that pressure ulcer. They went to the hospital, come back with the same pressure ulcer. Because it was originally acquired outside the facility, it is going to still be present on admission. All right, so this is our resident that came in with a stage 2. They go to the hospital. They're out for a few days. They come back, same stage 2. It was present on admission before. It's present on admission now. Yes? Yes. Excellent. And number 7 here was updated as well. And that is if the resident who has a pressure ulcer is hospitalized and the ulcer increases in numerical stage during that hospitalization, the ulcer will be coded as present on admission at the higher stage for reentry. And this coding tip or instruction here was updated as well. And let me share with you a clinical example for this. Your resident leaves the nursing home with a stage 2 and goes to acute care. Upon return to the nursing home, that stage 2 is now a stage 3. This stage 3 is going to be considered present on admission. Okay? There's been a couple of great examples in some, I don't know if we want to call them flow charts or what we would call them here in the REI User's Manual that have been added. So this little graphic that you see on the top of the slide actually appears in the manual now. So let's take a look at these. Our example is that Ms. K is admitted to the facility without a pressure ulcer, but during her stay she develops a stage 2 pressure ulcer. This is a facility-acquired pressure ulcer. It's not present on admission. She was hospitalized and comes back with the exact same stage 2. This pressure ulcer is originally acquired in the nursing home, and it won't be considered present on admission when she comes back. The graphic really helps to document the decision-making here, and I encourage you to use these graphics as you're helping your staff and others understand the coding of these items. So in this scenario, Mrs. K came in without a pressure ulcer. She acquired one in the nursing home. She went to the hospital. She came back with that pressure ulcer at the same stage. Again, it was originally acquired in that nursing home, and therefore it's not going to be considered present on admission. Excuse me. But then we have Mrs. J, another example. And Mr. J. He is a new admission to the facility and admitted with a stage 2 pressure ulcer. The pressure ulcer is considered present on admission because it wasn't acquired in the facility. The resident arrived to the nursing home with it. He's hospitalized and he comes back with the same stage 2, unchanged from the prior admission or entry. And the pressure ulcer is still considered present on admission because it was originally acquired outside of your nursing home. Again, the graphic here helps to document the decision-making regarding coding. Mr. J came in with the stage 2 initially. Again, it wasn't facility acquired to start with. He went to acute care and he returned with the same stage 2 pressure ulcer. He continues to have an ulcer that's present on admission. You all good? Okay. Excuse me. So let's take a look now at each item in M0300, beginning with M0300A, stage 1 pressure ulcers. Before I do go through these stages, though, I want to stress that the definitions of in the manual have been adapted. CMS adapted, not adopted. Okay, so there was some minor changes, adaptations from the NPUAP or National Pressure Ulcer Advisory Panel's 2007 pressure ulcer staging guidelines. So those are what is currently used in the RAI User's Manual. We know that the staging definitions have been recently updated again, but what you are coding this MDS on has to be the MDS definitions. So you may have instances where documentation is a little bit different for MDS versus what you might have on your pressure ulcer staging sheet, but your documentation should tell the story as to why your MDS looks the way it is. Okay, so the clinical picture around that assessment is what's going to support that coding. And again, I can't stress enough, follow these instructions, these RAI manual instructions for coding. So what is a stage 1 pressure ulcer? It's defined in the RAI User's Manual as an observable pressure-related alteration of intact skin being a key word there. And the indicators when compared to adjacent or opposite areas of the body, you may have changes in skin temperature, whereas it's warmer or cooler. It may be a tissue consistency. You call it, might be a little bit boggy, a little bit firmer. It may be sensation. Your patient or resident may have an itch. They may have a little bit of soreness in the area. And they may also have that defined persistent redness. And we know in folks with darker skin tones that if we're looking for red areas, we're never going to find stage 1s, right? We need to be educating staff for looking at changes in skin color. It might be purple, it might be a little bit redder, a little bit more of a blue color, but we generally aren't going to find pink areas on folks with darker skin. So stage 1s are intact and changes in temperature, consistency, sensation, or color, and these all might be signs of that stage 1 skin damage. For a stage 2, M0300B is where the assessor is going to document stage 2 pressure ulcers. In addition to coding the number of pressure ulcers and the number of those pressure ulcers that were present on admission, the date of the oldest stage 2 pressure ulcer is going to be captured as well in M0300B. So what is a stage 2? It's defined as a partial thickness loss of dermis, presenting as a shallow open ulcer with a red or pink wound bed without slough. It may be an intact or open or ruptured blister. I want to draw your attention to that phrase, without slough. If an ulcer is coded as a stage 2, and then I look through your MDS and I get down to M0700 where you're defining the most severe tissue type, and I see slough, I'm going to say there might be a problem here, right? So we're going to go back and say, what is really going on? So I think Section M, for me as someone, looks at MDS, looks at consistency items, I think Section M is an absolutely ripe opportunity to look at consistency in coding. We know that certain stages are going to present with certain tissues. We know that there's not going to be slough or eschar in a stage 2, right? We know there's going to be epithelialization here. We're really not going to see, oh my God, it just went out of my head. Granulation, thank you, from the field there. We're not going to see that granulation tissue, right? That's not how stage 2s heal. So we're going to look at consistency across these items and really take that opportunity for staff education from a clinical standpoint and from an MDS coding standpoint to say, what are you really looking at here when you're assessing that wound? In M0300C, our stage 3 pressure ulcers, we're going to document those there in C. Stage 3 pressure ulcers are full thickness tissue loss. Subcutaneous fat may be visible, but underlying structures such as bone, tendon, muscle are not exposed. In other words, they're not visibly, you're not able to visualize them or directly palpate those underlying structures. Slough may be present, but it doesn't obscure the true depth of tissue loss. These ulcers may have undermining or tunneling. And in stage 4s, they're documented in M0300D. And these ulcers are also full thickness tissue loss with exposed bone or tendon that can be seen or be directly palpated. Again, slough or eschar may be present. These wounds often include undermining or tunneling. So what's the key definition between 3 or 4? They're both full thickness wounds. The key difference is that presence of an underlying structure. It's not depth per se, it's depth of soft tissue damage such that we're getting to these underlying structures, but it's not the centimeters or millimeters of damage, but the depth of the damage into the actual tissues. When you think about a stage 4 on someone's ear, it can be pretty shallow, right? Very shallow, where maybe they have it on their thigh or their buttock and it's a much, much deeper area, but it's really a stage 3. So we're really helping individuals who are coding this and who are assessing residents' pressure ulcers, really to get them to understand it's the structural changes that we're seeing in that wound that really leads us to stage one way or another. In M0300E, we're looking at unstageable ulcers due to non-removable dressings or devices. So for some reason, you can't see the ulcer. As the nurse, these always made me nervous, right? I didn't like these much at all. So what are some examples of non-removable dressings and devices? Primary surgical dressings, casts, or other orthopedic stuff that can't be removed. So I would say we're not getting a whole lot of these, hopefully. We tend to be able to visualize those wounds, even if we've got maybe a longer use dressing that comes off once or twice a week, we can still take that opportunity to evaluate and assess the wound. And then we have unstageable ulcers captured in M0500 that are unstageable related to slough and or eschar. And slough or eschar are both defined in the RAI user's manual. Both of these are dead tissue, they're devitalized tissue. When we look at slough, it is yellow, tan, gray, green, brown. It's usually stringy or clumpy. It is, maybe adherent to the base of the wound, kind of all across. You may also have little clumps of this. For eschar, that's usually, it can be soft in nature, but it tends to be that harder, kind of leathery substance that is black, brown, or tan in color. It may look like a scab, but certainly very different from a scab. These are very firmly adherent to the base of the wound, and often the sides or edges of the wound as well. So again, both of these are well defined in the RAI User's Manual, and the bottom line is they're both non-viable tissue, no question about it. In M0300G, these are our unstageable pressure ulcers related to suspected deep tissue injury. And let's take a look at this definition. I want to draw your attention here to one particular word in the second line. Suspected deep tissue injury is defined in the RAI User's Manual as purple or maroon area of discolored, intact skin. So I want to draw your attention to that word, intact skin, due to damage of underlying soft tissue. The area may be preceded by tissue that's painful, boggy, warmer, cooler compared with the adjacent tissue. Do note, again, that issue that it is intact. Okay. So it is your turn for a polling question. Miss N was admitted with a pressure ulcer on her right ischium on March 3rd, 2016. The ulcer was obscured with slough on admission. The physician debrided the ulcer on March 14th, and a full-thickness ulcer without exposed bone, tendon, or muscle was revealed. How will the pressure ulcer be staged in M0300 on the combined admission and 5-day assessment with an ARD of March 10th? Will it be A, unstageable related to SDTI? Will it be B, stage 3? Will it be unstageable related to slough or eschar? Or will it be a stage 4, as in D? And take just a moment, and the poll is open. You can go ahead and click in your answer. All right, just a couple more seconds there, guys. All right. We have unstageable as the predominant answer. Let's see which one is right. Unstageable. So why is this unstageable and not a stage 3 on the assessment ARD of March 10th? Hasn't been debrided yet, right? It's going to be debrided on the 14th. So on that 14-day assessment, we are going to have a stage 3. Oh, whoops. I guess I just gave you the answer to the next question. Let me see if you were listening. You look like you're listening. So following debridement, do you all agree with that stage 3? Sorry to give away the top secret. Stage 3. Thank you for the 11 of you that voted and the 10 or so of you that were listening. Appreciate that. Okay, it is a stage 3. All right, great job, guys. Oh, but there's one more question. Following debridement, will that pressure ulcer be considered present on admission? And go ahead and take your polling. A is yes, or B is no. See, lots of responses already. You guys are doing great for being this late in the day. I really appreciate your stamina. Must be a bunch of folks that work in nursing homes, right? Your hardy souls. Doing great. All right, 100% of you say it's present on admission. Well done. Remember that these slides with these correct answers are going to be posted on the website for you. I see every once in a while, I see somebody take a picture. I should have mentioned that earlier for you. Again, I know Mark mentioned it earlier, but they will be available. So good job there. All right, let's look at M0800. Now, keep in mind that the new revised quality measure is all based on M0300 for this SNF QRP. This MDS item, M0800, is a fantastic opportunity to look at consistency in coding. right, to look at what really happened in tracking changes. We're capturing in this item, M0800, we're looking at worsening of pressure ulcers since the last assessment. For purposes of this item, I want to stress to you that we're looking at worsening a numerical stage. So if you go in there and you had a kind of shallow stage 3 and now you have a really deep stage 3, clinically you're like, yikes, that's not looking so good. But for MDS coding, we're looking at the increase in numerical stage that's really impacting the coding of this item. There's no question that tracking of changes of pressure ulcers is good, is consistent with good quality care and certainly appropriate. So why are we doing this item? When a pressure ulcers newly develop or worsen, a reevaluation of the interdisciplinary care plan should occur with the goal of ensuring that prevention and management measures are appropriate for the care of that resident. Oops. Sorry, I was a slide ahead there, slide behind. But rationale, again, planning for care. This item is all about helping trigger a plan for care, making sure that we're reevaluating when there is a change. So I mentioned earlier that worsening for this item equates to progressing to a higher stage. In other words, there's a deeper level of tissue damage than the previous assessment. When there's no evidence of skin breakdown, the MDS is going to reflect 0 pressure ulcers here. What's the look-back period for this item? It is to the ARD of the prior OBRA or scheduled PPS. If the assessment is being completed for the first time, so it's the first assessment for that resident, this item is not completed. So let's look at the steps for assessment. We begin by reviewing the history of each pressure ulcer, specifically that we're looking to how it currently appears to past stages to determine whether that ulcer is new or increased in numeric stage compared with the last assessment or since admission, entry, or reentry. And it allows, again, we're comparing, we're looking at that medical record documentation and really considering what's going on with these ulcers, the status of this resident. For each stage, we're counting the current ulcers that are new or have increased in stage since that last assessment. Remember, we're considering ulcers that are stage 2, 3, or 4 only here. And then we're going to enter the number of ulcers that were not present or were present on a lesser numerical stage on a prior assessment. And if there's no ulcers, we'll code 0 in that. So some coding tips. Clearly having a system in place that ensures documentation of pressure ulcers over time, including changes in ulcer status, makes coding this item easier. More importantly, it makes clinical care more appropriate for that resident. And ulcers are considered worsening if a numerically staged ulcer increases in numeric stage. There's some additional coding tips with scenarios that I'll review and again try to offer some kind of clinical scenarios to support these. The first is if a pressure ulcer was unstageable on admission, entry, or reentry, don't consider it as worsened on the first assessment that if it's stageable. So if your resident comes in with an ulcer that's unstageable due to slough or eschar, and the provider debrides it, and then it's a stage 3 is revealed, it is not new or worsened. Are we going to consider that present on admission, though? What do you think? So they come in with an unstageable, it's debrided, now it's a stage 3. Present on admission? Yes, excellent. If a pressure ulcer was numerically staged and becomes unstageable due to slough or eschar, do not consider this pressure ulcer as worsening. The only way to determine if the pressure ulcer has worsened is to remove enough slough so that the wound bed can be visualized. And once that's happened, that it can be visualized or palpated, then the wound is staged and the determination of worsening is made. So an example of this, you may have a resident who has a stage 3 ulcer. It's covered with, and then becomes covered with slough. That stage 3 that becomes covered with slough is a great example of clinically, yikes, right? Clinically, it's worsened. But for this item, you're only coding 2s, 3s, and 4s, so that's covered with slough ulcer is not going to be captured here. But once it's debrided, you see it's a stage 4 ulcer. Now it is new or worsened, so now it's reflected here, stage 4, new or worsened. Is it present on admission? No. Correct. Great job, guys. If a pressure ulcer was numerically staged and becomes unstageable, and again, subsequently debrided, so you can numerically stage it, you're going to compare the numeric stage prior to it becoming unstageable and after, and then you're going to consider that when you're coding it. So if the ulcer's current stage has increased, you're going to consider that as worsened. So that's the stage 3 becomes unstageable, it's debrided, now it's stageable again at a stage 4, it's new or worsened. And if 2 pressure ulcers merge, you don't consider them as worsening. Again, clinically, you might be saying, yikes, what's going on here that we now have 1 giant ulcer instead of 2 little ulcers. But although those 2 ulcers have the surface area may have increased, overall size of that ulcer, it's not increased in numeric stage, and only once it is increased in numeric stage is it considered new or worsening. So 2 stage 2s merge, they become 1 big stage 2. It's not new or worsening. 2 stage 2s merge and become a stage 3. It is new or worsening. Okay? And then if a pressure ulcer is acquired during the hospital stay, you're going to, its stage will be coded on admission and be considered present on admission or entry or reentry. It's not going to be coded in this item. If it worsens in the SNF subsequently, it will be captured. And if a pressure ulcer increases in numeric stage during a hospitalization, its stage is going to be considered present on admission. And again, it won't be coded in this item. And the clinical team will certainly recognize that there's been a change in the status and act accordingly with the clinical assessment. So I have a coding scenario for you. This is not a polling question. This is an opportunity to work with Mrs. J's discharge assessment, coding that for skin. So for in your packets that you have if you're in the room and in the supporting materials that are posted online if you're participating remotely, the couple of things that you will need are the excerpt of section M. So it's like 1 page that just has M0300 and M0800. And you'll also need the case study that you used for the ADL exercise earlier today. You will use that same case study. I'm going to give you a little bit less than 10-ish minutes, and then we'll debrief this. So my watch right now says about 12 minutes till 4. I'll come back about 5:04 and we'll debrief from this. Okay, so work together at your tables, talk amongst yourselves, and I'll see you in a few. Okay, guys, it seems like most of you are wrapped up here. Everybody good? You need more time or no? Okay, well, let's go ahead and debrief on what we saw for Mrs. J. And remember, we're coding her discharge assessment here. So how would you code M0300? The current number of pressure ulcers at each stage. What do you think for stage 1s? 0. How about stage 2s? 0. Stage 3s? 1. And just why are we coding it that way? On May 9th, she had that purple area she was admitted with, but then it was noted later to be a full thickness wound without bone, tendon, or muscle, visible or palpable. Great. How about stage 4s? 0. How about the other 3 items that are here? 0. Oops, I went the wrong way. 0, 0, and 0. You all agree? Well done. So is this ulcer, that stage 3, is it present on admission for her? Yes, it came. She was admitted with an unstageable ulcer. The first time that ulcer became stageable, it was a stage 3, and it's healing up, and she's going to be leaving our facility. Great. And then how about M0800, worsening in pressure ulcer? How did you code this item? Hear lots of zeros. You agree? 0 stage 2, stage 3, and stage 4. Nothing got worse during her stay. They only improved. So with that, I'm going to ask if there's any questions related to Section M. If there are, come on up and ask them. Otherwise, we're going to just pull the folks who are going to be coming up to answer questions together, and we will be back in 10 or so minutes to answer questions if you have them at the mic or if you've already submitted them. Thank you guys very much.